I have the pleasure of presenting Chanel Porchia-Albert. She is a trained doula. She's a nutrition coach, and she is a postpartum coach as well. Since 2008, Ms. Porchia has dedicated the last 10 plus years to addressing health disparities with minorities in maternal and infant care. She has founded the Asian Son Doula, an organization focused on bringing full spectrum doula services and classes to populations which are often overlooked within marginalized communities. Ms. Porchia has worked internationally. She traveled to Uganda, where she worked as a maternal health strategist and as a board member of Village Birth International. She assisted moms in rural and underdeveloped areas. She also contributed to Ariadne Labs at Harvard School of Public Health and Columbia University Medical Schools. She currently serves as a consultant on birth justice and provider engagement within the New York City Department of Health and Mental Hygiene. I've seen you as a speaker at some other forums. Her philosophy is that everyone deserves to have equitable healthcare that addresses their own particular needs. Please help me in welcoming Ms. Porchia.
I know it's really early, so thank you for inviting me here, Mount Sinai, and thank you all for being here bright and early and bubbly. I hope everybody had their shot of caffeine, and the IV line is ready to go. All right, so today I'm going to talk to you about shifting from competency to humility and an active framework for addressing biases within care. Overview really quickly, and we're going to go through birth justice, racial disparities, talk about frameworks, and demonstrate. At the end of this, you should be able to be like, oh, wow, you're a human being too. Okay? All right. So some of the stuff that I am going to talk about may be a little bit triggering. Some of the stuff that I may talk about may be stuff that you have heard, but maybe not. So we're going to talk about the origin of gynecology, hospital systems, implicit bias, racism, and maternal health. Does anybody know who this is? No. Yes? Who is he?
There's the one who did the experiments.
Okay. All right. So J. Marion Sims, or Dr. J. Marion Sims, is considered to be the father of gynecology, but he also practiced and perfected the fistula technique on enslaved African women. In particular, 3, one of the names was Anaka, where he proceeded to perform 30+ procedures on her without any form of anesthesia, although it was readily available at the time. When his colleagues could no longer stand the screams of the individuals, he would get other enslaved African women to restrain her or them and continue with the procedures. And so I just started from this realm because I want you to know some of the foundational principles of when we start to talk about racial biases and implicit biases, where some of that may come from. And so I also want to talk to you about hospital systems. And so a lot of us get into this work, but we don't necessarily know and have a clear understanding of US hospital systems and how they even came into fruition to begin with. And so, you know, prior to the inception of hospitals, everybody got cared for basically in their home. If you think about care, it typically took place where we had maybe a local midwife or herbalist, or maybe it's a shaman or someone that was in a particular town or village, didn't matter where you came from, there was that one person that was there. At the advent of family medicine, then you had doctors who were doing house calls, which no longer takes place, but it would be really nice if you all started doing that again. But during the enslavement of African individuals, what would happen is the midwife who was there, who was also enslaved, was usually rented out from plantation to plantation. It was forced to provide services, whether it be the medical needs of enslaved Africans and or deliver their children. And so the American hospital system, as we know today, emerged over a course of about 60 years, around the time of the Civil War. And it was physician staff with professional nurses and specialized services. but didn't really meet the needs of the populations that were there. And then we had the advent of Medicaid and Medicare from 1965 to 1980. And so during World War II, an impoverished underbelly could not be ignored. And so we have the New Deal that came about, trying to find ways in which to be able to really take care of those who were underserved and who otherwise couldn't afford to pay for healthcare services. Has anyone ever seen the show The Nick? Right, so if you've ever seen the show The Nick, and if you've never seen the show The Nick, that's your homework, to go check it out. But The Nick takes place right here in New York, right? And it shows you how the hospital-based systems worked. So think about it, if you are sick, and if you can afford an ambulance, you had to pay for the ambulance on the way there, otherwise they left you on the side of the road. When you got to the hospital, if you couldn't pay, they weren't seeing you. And so many people went without medical care, or they went to the underbelly or underground to get healthcare services when needed. And so from its inception, Medicare and Medicaid just never worked, just so you know. It never worked, still ain't working now, so we all know that, right? And so safety net hospitals were created. And so this was there to cover at least 1/4 of the poorest patients, where Medicare never paid more than about half the cost of care for seniors. And the cost rapidly amounted to about 900%. All right, so think about it. You have now hospitals that are underserved, staff that is overworked, patients who are not being served because guess what? The staff isn't being taken care of. And so you have an influx of just poor conditions and situations. And so we have to think about how insurance in and of itself dictates how people access care. And so some of the things I want you to think about, and we're not gonna break into groups because we don't have time for that, is how does insurance type impact the way in which someone accesses care, right? And so think about it. We're here at Mount Sinai West, but most people can't come here, right? You have public housing right across the street, right? Individuals who may sometimes even come and walk through these doors, but given the fact that they can't pay the high cost of services, they may not necessarily be treated or feel like they can't be treated. All right, so now we're gonna talk about a little bit about racism and implicit bias. I want you to think about what implicit bias is. And so implicit bias refers to the attitudes or stereotypes that affect our understanding, actions, and decisions in an unconscious manner. And guess what? We all have them. So when my bio was read and you probably heard, oh, she's a doula, your biases probably were like, oh God, here we go. This one's gonna be talking about rubbing backs and aromatherapy, right? Right, come on, let's just be real, right? You're like, listen, I spent all this money, I'm still paying on this student loan. I don't know what rubbing back and aromatherapy is gonna do for me, right? But we all have them, right? We walk in rooms and we make assumptions about individuals based on the things that we have encountered, our perceptions of individuals, our lived experience around others, and social media. But how does that show up within healthcare, right? And so it shows up in the interactions between the patient and the provider. It shows up in not listening to a patient of color or when someone is expressing pain, discomfort, or when they're visibly in distress. It's biases connected to patient identity, whether it be their education, race, gender, nationality, and how that translates into decisions being made about a patient's care, right? And you can sit here and say, no, I don't do that, that's not me. But that's not reality. The reality is that we all have biases, and that's how we're able to navigate the world in a safe way, right? And so I want you to know that there's levels to this though, right? It's not like just, oh, it's right there in your face. And so there's institutionalized racism, and that's where structures, policies, and practices and norms resulting in differential access to goods and services and opportunities are based on race. And so someone having access to be able to walk through this door and to provide a presentation to you could be dictated by the color of their skin. It's personal, and so it's differential assumptions about abilities, motives, and intentions of others based on race. So you happen to be walking down the street, you see a black man with a hoodie on, and you get nervous. You happen to be on a plane, you see someone with a turban on, you get nervous. You happen to see a patient who comes into the emergency room and you've seen them quite a few times and they're talking about pain, and you automatically assume that they want medication for a drug addiction. It's internalized racism, and that's acceptance of entitlement of negative messages by stigmatized and non-stigmatized groups, right? And so how have you also internalized that racism yourself? It's Venus, right? Or Serena and her baby, right? So we have beautiful Serena Williams, and for all intents and purposes, she was on the come up. She came from Compton, right? Compton is considered to be a low-income, marginalized community. Why? Because people of color live there. And she is now rich, and she's famous, and guess what? She's married to a white man, right? And so in some instances, some might say, oh, wow, you may have access to whatever you want. But that's not necessarily the case, because she went to the best hospital, she had the best doctors, and still she had to advocate for herself and for her body and for what she needed. And she was consistently told, no, that is not the case. No, the way you feel is normal. No, no, no. Until finally they actually listened to her. And so that's why we have a need for birth justice, and why I have to even stand here and have this conversation with you. And so birth justice, what it is regardless of race or gender identity, it's the individual being able to make an informed decision during pregnancy, childbirth, and postpartum for themselves and their babies without fear of coercion into unnecessary medical interventions, reprisal for refusal of that care, face inadequate medical care, and are able to express their full human rights around their reproductive health choices. So you might say, what do you mean fear of coercion? We don't coerce anybody to do anything. Think about this. You have a patient who happens to they're being induced. And at this point, they have had Pitocin. They may be about, 6 centimeters dilated. Maybe they're at station, we'll say 0, right? So we're halfway through the gates, right? 80% of face. And now you start to notice that there's D cells, or you start to notice that there's low blood pressure. And all of a sudden, 5 or 6 people rush in the room. What happens when you rush in a room on someone? They get scared, right? You tense up, right? You automatically are nervous. And so you figure out the situation, you tell them to turn on their left side, you're like, all right, everything's good, you're sterilized, and everybody leaves. But what has happened to this patient? What's happened to them? They're still in a state of panic. They're still in a state of fear. They're still in a state of concern, right? And they haven't had any kind of reassurance that everything is okay. So then the next time you come in the room and you say to them, you know what, I think we may have to give you a cesarean, the person is automatically going to comply because they're afraid, right? They've been placed in a position of fear to comply, right? And we don't even think about this, our reactions and the reactions that we have on individuals when we are doing those things. It is education, autonomy, dignity, accountability, informed consent, and it's intersectional, and most important is support. Because at the end of the day, that's what people want, is they want to be supported. They want to know that someone genuinely cares about them, and they actually see them, and that they're being heard. And the education comes in the form of understanding all possible outcomes, having resources and social support, information about the institutional protocols, policies, and procedures. It's resources in language and literacy level that a person can understand. It's having support persons or family members joining the conversation of a care plan, so they're not doing it by themselves. They're keeping patients up to date on any staffing changes and rotations and group practices, and it considers how the patient requests can be accommodated. How can we work together collectively? Because it's a team. It understands that you too need to continue your education, and you should be learning something new every single day when you do this work and any work that you do. You understand the root causes of racial, ethnic health disparities, including racism and discrimination. You have awareness and mitigation of provider perceptions that exaggerate Racial ethnic disparities is cultural humility and patient-centered communication. And it's the doula role and responsibilities. Understanding that we're not here as doulas to try to take over a scene. We're just here to provide information and education so someone can make an informed decision about their care. That it's not coming from a centralized vacuum. It's informed consent that is non-judgmental, it's comprehensive, and it understands all procedures, tests, and treatments. It's approached at a time when a patient feels prepared to make a decision, not in emergent situations or during a contraction. It's time to ask questions and reach a point of comprehension before making a decision. It's the autonomy to make and change decisions without fear of reprisal from staffing. Remember that at the end of the day, this is their body. And I know that you have been taught to do no harm, but again, this is their body. Is staff courteous and respectful to patients' concerns and wishes that move from the original plan of action? Well, I wanted to, be able to eat and drink. I want to be able to stand up. I want to be able to move around. It's understanding the natural physiological process of labor, that labor actually takes time. It's autonomy to make decisions based on values, religion, gender identity, sexual orientation, past trauma, and beliefs. And it's the importance of documenting patient decisions to assist them in advocating for themselves. So them having access to their patient records and knowing who's there and in a room with them. It understands that quality of care is important, and it's evidence-based, it's best practices that incorporates a human rights framework. So it's not just about the science of it all. You have to understand at the end of the day, you too, at some point or another, are a patient, right? And so in understanding that you too might also be a patient at some time, you want to be able to understand that evidence-based, yes, is important, but the best evidence is the person themselves because they've lived in that body since the day they came out of someone else. It's safe in a clean environment, it's courteous staff, and it's having accountability mechanisms. Mechanisms that ensure the patient's safety and satisfaction, but guess what? Your own as well. You being able to report injustices or things that you see without fear of reprisal from your institution. So it's also taking the provider into consideration. It's dignity and non-discrimination, fair and equal treatment regardless of race, gender identity, sexuality, age, disability, immigration status, etc. It's reliable, it's protection of privacy, it's respect of name and gender pronouns for the patient and the baby. It's respect for patient family structure and circle of support, whatever that may look like for them. And it's the acknowledgement of the patient's concerns and complaints, including information about grievance processes. And it's support. It's encouraging and it's welcoming because guess what? We all need support at some point. And it's a culturally appropriate resources and referrals for medical services and social support. And so what does a positive encounter look like? So then it looks like trust. You build trust through small interactions that can help if things get difficult later on and complications arise. It's, hey, guess what? My name is so-and-so and I'm here to assist you today and I'll be guiding you through your process and whatever that looks like for you. It's trauma-informed, so it considers verbal and physical triggers to a patient. So if you happen to be working with someone who has experienced past sexual trauma, it's saying to them, you know what? It's asking questions. It's consent that's continuous. Is it okay if I touch you? Is it okay if I give you a vaginal exam? Okay, I'm going to insert my fingers now. Okay, I'm going to insert them a little bit deeper. Please let me know if that feels uncomfortable to you. It's respect. And respect the knowledge and experiences of the patient brings to their care regarding their bodies, their histories, and what works well and what doesn't for their specific case. It's individualized care. And so that leads us to cultural humility and what does it mean to be humble within the work that we do? So Dorothy Roberts is a professor and scholar, and she's written quite a few books. And so she sums this up in a tweet that was put out in March. She said, to sum up threads on race-based medicine, one, it's rooted in concepts of innate racial difference used to justify slavery. It makes unproven diagnostic assumptions where there are better measures. It leads to denial of medical care and benefits and obscures structural racism. Racism's harm to health. Many doctors will respond, but I practice race-based medicine in a non-racist way. And even if that were possible, why defend a practice that causes harm? Why not work towards structural, competent, anti-racist medical practices? So what does it mean for you to practice anti-racist medicine? A medicine that comes from a place of understanding power and privilege, and that at any given moment, power and privilege happens and can shift. And so cultural humility basically works from a framework of values, and it affirms the potential differences between a provider and a client within language, religious beliefs, values, age, gender, race, and understandings of health and illness or sexual orientation. Its model is focused on understanding the client's health concerns, experiences, and preferences for care. And it encourages developing an attitude of not knowing and learning from the patient. That's time consuming, I know. You're like, listen, I can only spend 15 minutes with someone, but it only takes 15 minutes to get to know someone. And so I want to show you the difference between competency and humility, because a lot of times people are like, oh, you need to take a cultural competency class, right? Oh, you need to do cultural competency. Cultural competency is just a checkbox. Oh, yep, I did this. Oh, yeah, I understand we're different, right? And so the goals of competency is to build an understanding of minority cultures to better and more appropriately provide services. Humility is a personal reflection and growth around culture in order to increase service providers' awareness. It's internal. It means you gotta look within yourself. And competency is about knowledge and training, and humility is about co-learning and introspection. Some of the shortcomings to competency, it enforces the idea that there is competence in the culture other than one's own. Basically, you can know somebody's culture better than themselves. Humility is challenging for professionals to grasp the idea of learning from a client. This debunks everything that you learned in medical school, okay? It's no end result, which for those in academia and medical fields can struggle with, because it's continuous, it's ongoing, it's never ending, it doesn't stop. Some of the strengths of competency, it allows for people to strive to obtain a goal. And humility encourages lifelong learning with no end goal, but rather the appreciation of the journey and growth of understanding. It puts professionals and clients in the space of beneficial relationship and attempts to diminishing damaging power dynamics, understanding your role within a space and how we take up space. Think about it. On your way here, you're probably on the subway, or it's during rush hour. And you know that one person that gets on who's got the big ass, excuse my language, the big ass book bag on, who's knocking everybody around, and you're like, you didn't know that you had that book bag on your back? Right? And so it's understanding that power dynamic and being really mindful of the space and how you take up space. It's an emotional colonization that can be overpowering, dominating, and take away the autonomy by manipulating and disempowering or judging an individual. Guess what? It's not allowing people to trust their own intuition. You probably don't trust yours. So it means you gotta learn and work on that. It's interrupting them when they're speaking. It's acting dismissively when they share a personal story. It's ignoring or dismissing their emotional state. It's fixing their problems for them and taking away their power to fix them themselves, right? It's language like, I'm going to do this. We are going to perform a cesarean now. It's giving directives instead of asking, incorporating that individual within their care. It's taking over their emotions and feeling them deeper than themselves, because I know better than you. It's over-explaining things, assuming that they can't understand otherwise. And it's worrying about them in a way that implies that we don't trust them enough to look over themselves. Think about it. Think about child rearing. If you don't have children, I'm sure you probably babysat a child or saw somebody child rearing, right? And how, well, sometimes you'll see the overprotective parent where they never want to see their child fall. Every time they run, they skip. They're like, oh my gosh, it's okay, it's all right. Right? Instead of allowing the child to be themselves and to make mistakes, because that's okay. Because that's how you learn. That's how you grow. And so some of the best practices is to lead with the understanding that the patient as a person with a complex identity, like you. It understands that disease is not the only issue. When someone is coming to see you, you have to think about their emotional, their physical well-being as well. It's not just about the bits and the pieces. It's about whole body wellness. It's listen more than you speak. I know it's hard. Some of us like to run our mouths, right? But take a moment. Think about it. Say, wait a minute, am I talking too much? Right? And be aware of your power and work to provide resources for your patients to empower themselves. You can't empower anybody. The only thing that you can do is you could provide information, and it's up to them to make a decision, because again, at the end of the day, it's their body. And so I want you to consider these questions, right? And I think what's most important out of all of these questions is number 6. It says, what did you learn from your cultural group about how to manage conflict and how to handle your own and others' emotions? Think about it. Think about the way you were raised. Think about the interactions that you've had with individuals since you were young. What was your experience like? Did you grow up in a household that was loud? Did people not really talk to each other? Were people dismissive of other people's emotions? Did they walk away when you tried to speak to them? Did they give you the silent treatment? Maybe some of you are in relationships right now where people interact with you like that. And how is that reflection of how you also provide care to other people? Thinking about how your own conflict management and the way in which you interact with others, don't think it changes because you walk into a room as a physician. And it means that you are humble about the assumptions that you make, you understand your own background and culture, you motivate yourself to learn more about other person's background. Think about when you go on vacation. Why do we go on vacation? We go because we want to be free, right? We don't want to worry about bills. We're like, F that, right? If you got children, you like, bump that too, right? But we have to think about the impact that we have on other people when we go into their spaces. So even when you go on vacation, you are leaving a footprint for the people who actually live there every single day. What type of footprint are you trying to leave, right? It's to begin to incorporate this knowledge into your work. It's lifelong learning. It doesn't stop. It's continual, and it emphasizes respect, and it negotiates services and plans. Again, at the end of the day, all of you will be patients at one point. Either you will maybe have children, maybe you won't. Maybe there'll be another health crisis or something that may be going on in your life. And the way in which you receive care is going to be critical, because it's not just about the treatment. The treatment, along with the emotional well-being of the individual, is what makes people feel well. Let's get that. So, in thinking about reproductive justice and how it incorporates all of these things, reproductive justice is when people have the social, political, and economic power and resources to make healthy decisions about themselves. It transforms power inequities. It's long-term systemic change, and it relies on the leadership of communities. It understands that individuals are part of families and communities, and our strategies must uplift entire communities. You're in a community right now, but I bet half of you don't know any of the people who live across the street, or even walk across the street to the housing that is right there in your neighborhood. It's not about just being an institution in a space. It's about being an extension of the community in which you serve. When people know that you genuinely care about them, they're more apt to trust you and want to seek out services from you. Because at the end of the day, a good name is better than gold, right? The majority of the clients that you receive, if you decide to go into a private practice or work in a group practice, guess where it comes from? It comes from word of mouth. And you know, women, we like to run our mouths, right? We'll be like, yeah, girl, let me tell you how this doctor so-and-so, he was on point. He was kind, he was friendly, right? Or, yeah, she was great, right? I was able to, eat and drink, and they listened to me, and they didn't force me into anything, right? They were exceptional. They provided care that was above and beyond. And guess what? More people will walk through your door. We'll skip this part, but this is just a history and a timeline of how reproductive justice framework came into fruition, and the reproductive justice framework, just so you know, when sometimes people hear reproductive justice, they think about just abortion care, and that's not what it's about. All right? Reproductive justice framework was designed by women of color because when the feminist movement came around, our voices were not necessarily being heard in spaces. And so it is really a pinpoint to define where people have been and where we continue to go. It's intersectional, it's a human rights framework, it focuses on self-care and a bodily autonomy. And it operates in 3 modes of reproductive health, which is service delivery. That's what you all do, direct services. It is rights, which is the legal and advocacy portion of it. So when someone experiences an injustice, they know where to go to so that they can be heard. And it's justice, which is organizing around a particular issue, having access to abortion care, having access to equitable prenatal care, having access to Medicaid and Medicare, equal reimbursement. It understands that exploitation is a systemic process and structure by which labors and energies of some benefit others. It's powerlessness and voicelessness in which a state of people do not participate in making decisions that affect the conditions of their lives. They lack autonomy and aren't respected by others. So why don't you create a space where people feel like when they walk in the door, they can feel safe and respected? It's marginalization, which is a systemic process which creates a group of people who the system cannot or will not use. I am a mother of 6 children. I have a 10-year-old son. I have 9-year-old identical twin daughters. I have an 8-year-old daughter. I have a 2-year-old daughter, and I have a 17-month-old son. And when I became pregnant, the first thing that I thought about, it wasn't about the joy of having a child. It was about the fact of how are they going to see that child when he gets older? My son, who is a vibrant young man who walks this earth and right now is in Tennessee at a national chess championship, competing against 300 students from all across the globe. He's sweet, he's gentle, he's a mild-mannered person. He wishes no harm on anyone. But when he walks down the street, some people see him as a threat. And as a mother, that should not be the first thing that you think about, but it is. It's cultural imperialism. It's the dominant meanings of a society read in that particular perspective of one group invisible at the same time as a stereotype that group and market as other. These meanings can become internalized in a marginalized group, and they may come to feel inferior or develop a double consciousness. The way in which I talk to you right now is not the way I talk to people outside, right? It's called code switching. Violence. It's a social practice in which members of a group live with the daily knowledge that they must fear random, unprovoked attacks on their person or property, which have no motive but to damage, humiliate, or destroy the person. You happen to be walking through, you see a person of color walking through a suburban area, and automatically you think, why are they here? Right? We make assumptions. And it's defining what those issues are that affect individuals on a consistent basis. It's understanding that structural oppression and the ways in which history, culture, and ideology, public policies, and institutional practices and behaviors interact to maintain a hierarchy. Are you a part of the hierarchy, or are you trying to dismantle the hierarchy? Right? And it's not talking about socialism of any sort. It's just really talking about basic human rights and autonomy for an individual to be able to walk and live and breathe on this earth like a human being, like they should be. It's the privileges associated with the dominant group that disadvantage an associated group with the oppressed or targeted. Think about recently the outing of the actors and actresses who paid for their children to get into school, and then think about affirmative action. It's intergenerational trauma, and it's the transmission of historical oppression and its negative consequences across generations. My mama had a C-section, her grandmother had a C-section. Oh, that one had a C-section. I'm bound to have a C-section too. Oh, my grandmother was in poverty. My mom grew up in poverty. Oh, we're gonna grow up in poverty too. It's understanding that everything is systemic and that the cultural, institutional, and personal, they all work together, hand in hand. And so you too are part of that culture, that institution, and your own personal beliefs play a role in how that system continues to play out itself. It's understanding that the dominator culture has tried to keep us all afraid, to make us choose safety instead of risk, sameness instead of diversity, moving through that fear and finding out what connects us, reveling in our differences. This is the process that brings us close together, that gives us a world of shared values and meaningful community. At the end of the day, that's all we really want, is a shared community, right? We all create our own community. Some of us create intentional communities. You're like, yo, I can't deal with all of this. I'm going to live off the grid, all right? And it's values. And some of the key values are education, self-determination, autonomy, respect, dignity, access, and options. Because you could say, "Oh, well, you have option. Everybody has these access. You have access. You can go right here. You can go there." That doesn't mean that's where you want to go. That's like Shake Shack and White Castle, right? It's mental health. It's advocacy for others and yourself. It's anti-racist. It's support. It's the environment and healthy communities. It's an anti-oppression model. It's family-centered. It's freedom. It's freedom. We always talk about freedom in theory. Like, yes, I want to be free, right? I just want to be free. I just want to let loose. I want to chill, right? But freedom is something that you can build. It starts inside. And then it can go outside. It's equity, it's informed consent, and it's whole body wellness. And it understands that there's some big challenges that we have to overcome just to even get there. Capitalism, ooh, you're like, wait a minute, but I really like that Fendi bag. That new Lexus is looking nice. Or that Tesla, right? It's environmentally friendly and it's stylish, right? It's understanding what white supremacy really is. It's commodified health. Think about it. Patient care has been so commodified that you too have physical restraints on the way in which you can provide care, right? Thinking about malpractice insurance and how that's going to affect the way in which you do things. Maybe you wouldn't do certain things if you didn't have that thing lingering in the background like a cloud. It's just care. It's misogyny. It's lack of accountability. It's low funding. It's insufficient public health education. It's modern medical model of care that doesn't understand the natural physiological process of birth. I probably could ask you right now, how many of you have actually seen a vaginal breech delivery? How many of you have had? Oh, we got one. We got two? Oh, shoot. 3. See? It's amazing, right? But that's sad, because everyone should know how to do that. Because it doesn't require a cesarean. It's understanding that labor is long. That's why it's called labor. It's a process. It's a marathon. That mess takes a while. It's painful. It's people that make noises. They will scream, they will shout, they may curse you out, right? But it's nothing personal, right? It's a process to get to the end where you feel this overwhelming desire of fullness and then you explode. It's like when you went out and got them White Castle burgers and you shouldn't have got them. And 30 minutes later, you were like, oh, Lord, right? It's understanding gender. It's about equitable data collection. It's about the medical industrial complex and how it affects all of us. You too in this room, you have to understand. It's provider and doula divide, thinking that the doula's in the room to co-opt the space. No. Well, some of them are, but I'm not. And the ones who I teach are not either. It's about us having a collaborative care framework and working together. It's doulas, nurses, midwives, and physicians. Understanding that you all are trained surgeons. You're supposed to come in kind of sort of at the end if some shit happens. But in case that stuff doesn't happen, guess what? We have all these people who know what the natural physiological process of birth looks like, and they're here, and we work together. Right? So you can sit back, you can chill, you can enjoy your latte, and you can allow the baby to just come on its own, because guess what? Babies deliver themselves, right? It's racism and understanding that it's institutional and it's at all levels. It's professionalization, it's awareness or being unaware. Some of us like to be ignorant on purpose. You know that person that you hang with who just act like they don't know shit? Right? Or you say something to them and they look like a deer in headlights, and you're like, I know you know I'm talking to you, right? It's empathy and unapologetic, it's generational, and it's policies, and it's working actively together to shift those policies. Listen, if you see something, it only takes one voice to say, nah, that's not right. Let's not do that. Let's try something different. And some of those solutions could be, oh, look at that, that's a community. Those are happy people with happy babies. It's advocacy. And advocacy can start as small as you wearing a pin, to you wearing a t-shirt, to you dyeing your hair a different color. People might be like, but I'm not political, I don't have those conversations. Everything that we do is political, I'm sorry to say. If you thought you were living in some kind of invisible vacuum that was non-political, that is wrong, okay? It's awareness and education, it's women and individuals knowing about their bodies, it's a cultural shift. It's time for us to use the tools that we have now, The world is in a place where it wants more. People want to be seen. Why do you think we have Instagram? People want to be heard. That's why we got a ton of podcasts, right? And people want to know that people genuinely care at the end of the day. It's educating young people, it's strategic alignment and collaboration with people who you probably otherwise would not collaborate with on a regular basis, right? It's dialogue and visibility, it's policy around racial discrimination, it's an increased inclusiveness of our birth justice framework. And you're like, how do I incorporate this into my work? Please come see me afterwards. It's insurance coverage of doula care, it's equitable medical reimbursement for midwives, doctors, physicians, everybody, right? Because it needs a whole system overhaul. And it's understanding that we all have to work together in order to make this work. Thank you. All right, so questions. Give me the questions, give me the questions. Now, people who don't ask questions make me nervous. Because you know what you'll do? You'll go outside the room and then you'll have conversations like, you know what? Da-da-da-da-da. So come on, I'm a real person. Let's have a real conversation. There's a mic there.
For most of the people here in the back are residents, the family medicine residents that work on the labor floor. Mm-hmm. Could you give us maybe like 2 or 3 actionable items or tasks that you think that would provide, competent and compassionate care on the labor floor? A lot of our residents labor with our patients, and our population is exactly the population that you described. Mm-hmm. And so some take home.
So, first off, it just starts by introducing yourself, and not introducing yourself with a resume. People who do that make me nervous, because it's like, who are you? Do you know who you are? Because you don't seem sure, right? But it's just introducing yourself, right? It's understanding that, individuals, when they come into your space, they're nervous. They're not sure what's happening. They don't necessarily, they may or may not have the education around what's going on. So just ask them, right? What brings you here today? How can I best assist you? How about you tell me about yourself, right? It's starting a conversation. Again, this little things can happen in 15 minutes. Introduce yourself, ask the patient about themselves. Who are you? Don't just look at what's on the paper. It's active listening. While you are actively listening, you should be writing stuff down. So carry a notepad around with you so that you can take down key information that they give you, so that when you speak to them again, you can report back to them exactly what they said, but in conversational style. So they understand, what you're saying to me is X, Y, and Z, right? It's understanding that when someone says to you, I'm feeling pain in a particular area, it may be the diagnosis is in textbook form. It's going above and beyond just a little bit to try to figure out what that is. Again, it's listening and seeing people. Think about how you would want to be treated. Think about when you walk into a space, and for my introverts, it's really easy, right? You're like, oh my God, it's hard for me to just speak to everybody on a regular basis. How am I going to speak to a patient? Just start with hi, right? At the end of the day, we're all human beings. It's just common courtesy. It's not anything people just want to be seen. They want to know that you are looking them in the eyes and that you see them, right? They want to be heard. They want to know that you actually genuinely care. I always, when I talk to providers, I'm like, I know that you all didn't get into this just because of money, because it's more student loans than money, right? And so it has to be because something within you wanted to provide service to others. And in providing that service to others, we have to understand that human compassion and understanding is something that you would want yourself. And so we have to provide that to the people that we see on a consistent basis. It's understanding that someone may be nervous or in fear. Think about it. If we start to think about the history of how people of color, these institutions were never created to serve people of color. They weren't. Black people and indigenous people have been treated horribly within medical care. Horribly. They've been researched on, they've had forced sterilization, they've gone into spaces where every time they walk through these doors, they are nervous, and it's probably the last straw, because they probably try to do everything else at home first before they even walked in here. And so it's understanding that. It's understanding that you're dealing with a population who is experiencing intergenerational trauma and histories that tell them that that person in that white coat is someone to be feared because they don't have your best interests at heart. And so you as a provider, the first thing you have to do is you have to break down that assumption, because that is a fear that has been around for 400 years. And so in conversation, you can do that, but it takes time. It takes a willingness to expose yourself. It takes you unlearning some of the things that you have learned about patient interaction, right? That you're not supposed to get too close. You're not supposed to have this emotional connection with someone. No, that's what people want. They want to know that you care. Because people who don't care, they don't trust. We go through that enough. People who experience social services, who speak to people in condescending manners, who are going through a revolving door in a cycle, even people who have private insurance. Before I started doing this work, I was a commodities broker, right? I know it's a crazy shift, right? You're like, why would you go from that to that, right? But I did, because that wasn't fulfilling. It was just a process of going and doing the same thing over and over and over and over again. And eventually you get burnt out from the monotony of it all. But when you do something that you're genuinely passionate about, that you care about, people see it. And they want to be around you. And they want to get care from you. Because they understand that, yo, this person really cares. Like they have my genuine interests at heart. And that's basically it. Any other questions? I know you had to get ready to go on the floor. Yes. Yes, so the question was, can I tell them a little bit about the organization, what I see the role of doulas are. Now, so Ancient Song Doula Services, it started out in my living room. It started out with me going into spaces, and seeing the way in which, when I supported individuals, how they were treated. I saw people use child protective services as a tool to get someone to comply with cesarean. I've seen individuals have their children, I've had patients who have been illegally drug tested without their consent because there was a perception that because they were hood or ghetto or spoke with a particular vernacular, that they had to be doing drugs. I've seen babies put on hold in NICU for no reason, and then bagged, and urine samples taken from them, just to see whether the child had, marijuana or any other substance in there without, well, you don't need a parent's consent for that. You can say it's a regular medical procedure. And so because of the things that I witnessed, because sitting in waiting areas and seeing people sit there for an appointment that's supposed to be at 1 o'clock and not being seen till 6 o'clock, that was a problem. I was like, are more people experiencing this? So the focus of Ancient Song is to provide full spectrum doula services. So we provide abortion doulas, labor, birth, postpartum, stillbirth, miscarriage, and everything in between. We're in Rikers Island providing services where people are forced to get inductions because they don't have anyone on staff in the evening. We are there to help people to advocate for themselves and provide information so that they can make an informed decision about their care. We offer non-judgmental care, which means that we're allowing the patient to be the patient, who they are. We don't make decisions for them at all. We provide emotional and physical support as well as information, evidence-based information, so that they can make an informed decision about their care. That's it. Ancient Song doulas in particular are trained to be able to work with providers in a very inclusive way, right? Understanding that in order for us to really have better birth outcomes, we have to all be working together as a team. All doulas are not the same. I'm gonna say that again. All doulas are not the same, right? Some doulas come from a different independent model of care. Some doulas were trained to only specifically care for white individuals who are middle class. The doulas that we have here at Ancient Song are particularly trained to provide services for everyone. We have doulas who speak varying different languages, who come from varying different backgrounds and religious beliefs. And again, it's just about, at the end of the day, bringing a human rights framework into the birth room. People just want to be seen. I can't say that enough. They want to be seen, they want to be heard, and they want to know that someone genuinely cares. The same way you do. The same way when we walk down the street and we intentionally avoid eye contact with other people, it's about not avoiding it. It's about allowing yourself to be vulnerable enough for people to see you. And in exchange, do the same. Because we're missing human connection. People want to be connected to someone. And that's what our role at Ancient Song and our doulas are trying to provide, that connection, that continuity of care that you all can't necessarily offer. So when you can only see a patient for maybe 15 minutes or 10 minutes, it's about, we're there the entire time. We do prenatal visits, sometimes up to 7, to get them prepared. We talk about, we go through childbirth education, we go about the stages of labor, we talk about medical interventions, we talk about what to expect, how to prepare, what does it look like when you go home. We talk about how to prepare if someone has mental health issues, or maybe they are substance, or maybe they have past sexual trauma. From the time that they go into labor and they call us, we are there with them, however long it takes to the very end. And then we stay for as long as it takes afterwards to make sure that they feel supported. And so while you all have these interactions that are transactional, we create a feeling of support, of someone who actually gets to know them, right? After they deliver, we'll stay with them for a minimum of 2 hours, but sometimes more. We'll go through them about breastfeeding, because we also know that a lot of people don't necessarily have breastfeeding education. Most of our doulas are certified lactation counselors. They also have been trained in mental health training, right, and other modalities. Then we'll do postpartum visits. And so 2 or 3 days postpartum, we're with them. We're staying with them for up to 4 hours. We're in their home. We're doing home visits, right? If we notice that we see anything around maybe signs of postpartum depression or psychosis or things of that nature, we will provide them with the appropriate referrals so that they can get the services that they need. Sometimes it goes up to 18 hours. And so we're offering that continuity of care where you all can't. So it's not about us like trying to work against you and not this, that, and the other. It's about us working together as a unit to make sure that we have the best birth outcome. So, because for a provider, right, a good outcome is a healthy baby and a healthy mother or a healthy pregnant person. But for the patient, they look at it totally different. It's also the experience, and we don't measure the experience as an outcome. And we need to start doing that, right? When we start to understand that, because at the end of the day, you could have said, yo, I did the best medicine that there was. And that person could be like, yo, my experience was trash. Like it was straight trash. And it was trash because you didn't connect. Because people walk in and out of a room, they don't talk to people, they don't have any kind of like real conversation, they don't introduce themselves like they're human beings, people act like they're robots sometimes, right? They don't explain medical procedures and things, they don't involve them within the process. Remember that this is their body. This is someone's body. This is not a cadaver who can't make decisions. This is someone who is living and breathing and who otherwise in any other circumstance, if you were to come into their house and tell them what to do, you would get cursed out and kicked out. And so they're coming into your home expecting to be cared for and to be treated with respect and dignity at the end of the day. Because at the end of the day, guess what? If they know that you genuinely cared and that they were involved in their process, even if the process wasn't necessarily something that they wanted, maybe they wanted a vaginal delivery and they couldn't get that. But even if they knew that that person went above and beyond to show them that they were involved in this process and that they weren't making decisions for them and that they were an integral part of the process, they'd be like, yo, this was great. I'll go there any day. I recommend everybody to go here. Right? Because again, it's about the experience. Think about why you all go on vacation and why you go to restaurants. It's for the experience. Why are we going to Nobu? Because we just want sushi? No. Because you want the experience. You want to be able to enjoy what the feeling of sitting there and savoring the food and understanding what that feels like. That's the same thing people want. Why do we go to the movies? Because we want that experience. Why do we go on roller coasters? Experience, the thrill, the excitement, the way it made us feel. At the end of the day, what kind of thrill and excitement are you going to give people? Are you going to give them something where they're like, yo, you know what? Never mind. Dr. So-and-so, don't go there. Don't do that. No, right? And so, A good name is better than gold. I can't say that enough. A good name is better than gold at the end of the day. Thank you.